Hello, everyone. Welcome to our Zoom meeting. Today, we're gonna have a couple of topics. Dr. Huzaifa and his team will start the meeting. So, Dr. Huzaifa, when you are ready, please go ahead and thank you so much.
Thank you so much, Dr. Nadir. Hello, everyone. We are so glad to be here today and so grateful. First of all, I'd like to thank you very, very much, Dr. Nadir, for giving us this opportunity and providing us such a great platform to share our work. This is the first presentation for us for the Navy Blue 1 team, and we are so glad to be here today. Me and my team, and we are very excited. Dr. Nadi said we have 4 topics today in the great presentation. So the agenda, let's start by the first topic. It will be presented by Dr. Liena and Dr. Shahad. They presenting the hearing loss in adult. Dr. Liena, do you hear me?
Hello everyone. Hello Dr. Nadir. Hello Huzaifa. Yes, I'm here with you. Me and Chad will be presenting hearing loss in adults.
Yeah, go ahead.
Okay.
Can you share your screen?
Do you mind sharing it, Dr. Huzaifa?
Okay. Is it clear?
Hello, everyone.
Yes, Dr. Lina, go ahead.
Yeah, hello, everyone. I'm Dr. Shad. I will present the hearing loss, the first part of hearing loss, me and Dr. Lina. I will head and start. By the end of this lecture, we will be able to describe the mechanism of normal hearing, the common causes of hearing loss, management and treatment options of hearing loss, and strategies to improve communication with adults with hearing loss. Move the next slide, please. We have different topics to be covered, like normal hearing, age-related changes that can affect hearing, epidemiology, presbycusis, clinical presentation and hearing loss detection, evaluation of suspected hearing loss, and treatment of hearing loss. So, hearing loss is the fourth most common chronic disease among older patients, often assumed to be benign, but profoundly affects quality of life. So it contributes to family discord, social isolation, loss of self-esteem, anger, and depression. It can be the treatment can improve quality of life by facilitating interaction with family, friends, and caregivers. And this is the impact of hearing loss on life. Normal hearing is sound energy which is transmitted through the external ear to the tympanic membrane and auditory ossicles. Malleus, incus, and stapes. It transmits vibrations to the oval window of the cochlea. Fluid waves stimulate outer hair cells, which stimulate inner hair cells. Then, inner hair cells generate impulses that are sent via cochlear neurons to the cochlear nuclei and then to auditory pathways elsewhere in the brain. So, if there is any change in this pathway, it will affect hearing. Aggregated gains that can interfere with hearing usually occurs in the external ear canal, which its walls becomes thin, or cerumen becomes drier, more tenacious, increasing likelihood of impaction. Or it can be in the tympanic membrane, which thickens and appear duller. Cochlea, hair cells, and fibrocytes in the organ of Corti are lost. Basilar membrane stiffens, auditory structures calcify, and cochlear neurons are lost. Cerebrovascularis, capillaries thicken, endolymph production decreases, and sodium-potassium ATPase activity decreases. This graph shows the epidemiology of hearing loss. The prevalence increases with age, with 10% of patients age from 65 to 75, and more than 75 years old, they have 25% of population have hearing loss. Causes and types of hearing loss. It may be caused by pathology in external ear canal, middle ear, inner ear, auditory nerve, central auditory pathways, or a combination. Categories of hearing loss based on cause. It may be caused by conductive hearing loss, sensory neural hearing loss, or mixed hearing loss. This graph shows normal audiogram and hearing threshold and the frequency. To the first part, conductive hearing loss. The pathology may be in the external ear, where there is cerumen impaction or foreign body, or the middle ear pathology, otosclerosis, osteoma, tympanic membrane perforation, or middle ear effusion. This graph shows the frequency and decrease hearing threshold in the conductive hearing loss. The second one, sensory neuron hearing loss, which is most often from age, noise damage, or ototoxicity. It may be caused by cochlear disease, which is the most common cause, and often from noise damage. Other causes include ototoxic medications, genotype, vascular disease, occupation and environmental chemical exposures, which is rare, and autoimmune disease or auditory nerve tumors, which is also rare. There's a graph. Dr. Huzaifa, can you hear me? Can you move to the next slide, please?
Yes.
Can you move to the next slide, please?
Yeah, I know. Hello?
Yeah, can you move to the next slide, please? Dr. Huzaifa, can you hear me?
Yeah, I move it.
Next slide, please. Yeah, Dr. Huzaifa.
Yeah, I'm hearing you. Did you saw the screen?
Yeah, there is graphs. Okay, presbycusis, which is a sensory neural hearing loss, usually symmetrical, and have central components. It's classified by cochlear pathology: sensory, neural, strial, cochlear conductive, combined, or indeterminate. Amplification usually helps in presbycusis cases.
It seems we lost Dr. Huzaifa. While he is gonna come back, I'm gonna share the screen with you, and we're gonna see if we can give me a second. So I'm gonna just show the pathophysiology of hearing. So can you?
Steps. The vibrations of a sound source cause the surrounding air molecules to move back and forth, creating a series of alternating regions of high and low pressures. A sound wave is basically a pressure wave. It propagates in the form of fluctuations in air pressures. The loudness of a sound is determined by the amplitude of sound waves, which represents the strength of vibrations produced by the sound source. The stronger the vibrations, the higher the amplitude of sound waves, the louder the sound. The pitch of a sound is related to the frequency of sound waves, which indicates how fast the sound source vibrates. The higher the frequency, the higher the pitch. Frequency is measured in hertz. A young human ear can detect sounds in the range of 20 to 20,000 hertz. Some animal species can hear frequencies well beyond this range. Hearing is the process by which the ear transforms sound vibrations into nerve impulses that can be interpreted by the brain as sounds. The human ear has 3 distinct regions called the outer, middle, and inner ear. The outer ear funnels sound waves through the auditory canal to the tympanic membrane, also called eardrum, which separates the outer ear from the middle ear. The eardrum is attached to a chain of 3 small bones in the middle ear, called the ossicles, the malleus, incus, and stapes. Sound waves cause the tympanic membrane to vibrate, and the vibrations are transmitted through the 3 bones to the oval window, where the inner ear begins. Since the eardrum is much larger in area than the oval window, the sound pressure that arrives at the oval window is much greater than the original pressure received by the eardrum. This amplification is essential for the stapes to push against the higher resistance of the fluid in the inner ear. The organ of hearing in the inner ear is the cochlea, essentially a long tube that is coiled up in a spiral to save space. The cochlea is composed of 3 fluid-filled chambers. The central chamber, known as the cochlear duct, is where mechanical vibrations are transformed into nerve impulses. There are 4 rows of hair cells within the cochlear duct, supported on the basilar membrane. The movements back and forth of the stapes push on the fluid in the cochlear duct, causing the basilar membrane and the hair cells to move up and down. These movements bend the cilia of hair cells, opening the mechanically gated potassium channels on their surface. Influx of potassium depolarizes the cells, stimulating them to send nerve impulses to the cochlear nerve and on to the brain. Our ability to differentiate sounds of different loudness and pitch depends on the ability of the cochlea to respond differently to different amplitudes and sound frequencies. Louder sounds cause more hair cells to move and generate greater nerve signals to the brain. Different frequencies stimulate different parts of the basilar membrane, which acts like a set of piano strings. The basilar membrane is narrowest and stiffest at the base, near the oval window, and widest and most flexible at the far end. High-frequency sounds with more energy can move the stiffer part of the membrane, while low-frequency sounds can only move the more flexible part. Thus, high-pitched sounds excite nerve fibers that are closer to the oval window, while low-pitched sounds send signals through the fibers at the far end. Thank you for watching. If you like our videos, be sure to check out our new Patreon page. Patreon is a simple way for you to contribute to our production.
So is Huzaifa back?
He's not back. I'll
He's not.
start sharing the screen from my side.
All right. Thank you so much, Dr. Liena.
Yes, okay, just a second. Shahad?
Yeah, thank you, Dr. Liena. This graph shows a mixed hearing loss as the hearing threshold decreases. Okay. Presbycusis, which is a sensory neural hearing loss, usually symmetrical, and may have central components. It's classified by cochlear pathology to sensory, neural, strial, cochlear, conductive, combined, or indeterminate. In this case, amplification often helps. Types of presbycusis. Sensory, which is loss of sensory hair cells in basal end of cochlea. It is a slowly progressive loss, beginning with higher frequencies. Usually patients have difficulty hearing in the presence of background noise. It is treated by amplification. When it comes to strial presbycusis, it results from atrophy of the stria vascularis and begins in 20s to 60s. It is mild to moderate hearing loss in most frequencies and usually have good speech discrimination, and is also treated by amplification. Neural presbycusis is cochlear neuronal loss of 50% or more. It has poor speech discrimination, and amplification is usually not successful. Cochlear conductive presbycusis, caused by kinks in cochlear mechanics, produced by mass or stiffness kinks or spiral ligament atrophy. Audiogram descends gradually over at least 5 octaves. Speech discrimination is impaired. The clinical presentation of hearing loss. Usually, many older adults unaware of their hearing deficit. Hearing loss can be interpreted as cognitive impairment. Changes can be an early sign of hearing loss. It may fail to respond to request or respond inappropriately due to misunderstanding of the speaker, and may complain about loud TV. Hearing loss detection. We can detect it by hearing handicap inventory for the elderly. It's a screening version, whisper test, handheld otoscope with a tone generator, apps, and online hearing tests. Evaluation of suspected hearing loss. We should exclude causes of hearing loss that are readily treatable or warrant referral to an otolaryngologist before signing medical clearance forms for hearing aids. Examine ear canals with otoscope to exclude obstruction such as cerumen compaction or fusion, and review medications list for potential contributors. When to refer to otolaryngologist? We should consult for asymmetrical hearing loss, which may indicate tumor of posterior pharynx blocking eustachian tube or auditory nerve tumor. Also, if there is cerumen impaction not responsive to ceremonylytics, irrigation, or manual extraction, or in patients with a history of tympanic membrane surgery or perforation. When to refer to audiologist? Consult to determine the presence and type of hearing loss, recommend and fit hearing aids, and provide auditory rehabilitation. Assessment include evaluation of pure tone thresholds for both air and bone conduction, speech recognition thresholds, speech discrimination, and middle ear function. So my colleague, Dr. Liena, will take over now.
Thank you, Dr. Shan. And for the treatment of hearing loss, we have it could be medical or surgical, using of assistive listening device, hearing aids, cochlear implants, and there are strategies to enhance communication. The medical could be in case of Badger disease and otosclerosis, we treat with bisphosphonates. And in case of sudden hearing loss, we use corticosteroids or immunosuppressants. The surgery could be in cases of otosclerosis and tympanosclerosis. One of the strategies to improve communication, we can ask the listener what is the best way to communicate with him or her, obtain the listener attentions before speaking, eliminate background noise as much as possible, and be sure that the listener can see the speaker lips. These can be by speaking face-to-face in the same room. Do not obscure the lips with hands or other objects. Make certain that light shines directly on the speaker's face, not from behind the speaker. And also by speaking slowly and clearly, but avoid shouting. Speak toward the better ear if applicable. Change phrasing if the listener does not understand at first. Spell words out, use gestures, or write them down. Have the listener repeat back what he or she heard. There are also assistive listening devices that can be pocket-sized, personal amplifiers, telephone equipment, such as amplifier, vibrating and flashing ring alert device, text, telephones, television listening device, vibrating and flashing device from alarm clocks, timer, smoke alarms, doorbells, and motion sensors, FM loops, and FM or infrared transmitter receiver system for groups. As for the hearing aids, it's always better 2 than 1, but not everyone benefits from the hearing aids. For example, those with poor speech discrimination or unable to tolerate the presence of hearing aids in the ears. They come in several types, such as analog and digital, the analog being less expensive, but it's rarely sold now, and digital, which is smaller and customizable. Effects and rehabilitation of hearing loss. It depends on the degree of the loss. In mild, the loss in decibels is from 25 to 40. They have difficulty in hearing whispers. This effect, the effect on communication is difficulty understanding soft speech or normal speech in the presence of background noise. They can use hearing aid. Hearing aid are needed in specific situations. In moderate lows, the loss in decibels is 41 to 55. They have difficulty hearing conversational speech. It affects understanding any but loud speech. Amplification, frequent need for hearing aid. The severe loss is from 56 to 80 decibels. They have difficulty hearing shouting and vacuum cleaner. They can understand only amplified speech. Amplification is needed for all communication. In profound degree, the loss is more than 81 decibels. They have difficulty hearing, hair dryers, heavy traffic, telephone ringers. They have difficulty in understanding amplified speech, may miss telephone calls. So they need supplemental hearing aid with lip reading, assistive listening devices, and sign language. We have several styles of hearing aid. They range from completely in canal, in the ear, behind the ear, body aid, and bone conduction aid. We're going to discuss each of them individually. As for the completely in the canal hearing aids, it's used in mild to moderate degree of hearing loss. Its advantage is almost invisible, less occlusion of the pinna, it's more natural sound, and easier to use with headphones and telephones. Its disadvantages are user's dexterity may be a problem, small size may limit available features, most score may cost more than the canal or in the ear aids, so it's a bit expensive and has a shorter battery life. Canal hearing aids are used in mild to moderate degree of hearing loss. Its advantages is it's more cosmetically appealing than larger aids, telecoil available in some models, and may be able to use with headphones. Its disadvantage is user dexterity may be a problem, small size may limit available features. In the ear hearing aids, it's used into mild to severe degree of hearing loss. Its advantage is it's easy to handle, comfortable fit. Options can be telecoil, directional, microphone, more power than completely in the canal or canal aids. Its disadvantage is it's more conspicuous than completely in the canal or canal aids, may be difficult to use with headphones. Behind the ear hearing aids are used in mild to profound hearing loss. Its advantage is it has the greatest power and have several options such as telecoil, directional microphone, direct audio input. Ear mold can be changed separately. As for the disadvantage, it's more conspicuous, may be more difficult to insert than the ear aids, and it's difficult to use with headphones. Then we have body hearing aids, which are used in severe to profound hearing loss. Its advantage is the greatest separation of microphone from receiver, reduces feedback. And the advantage is it's most conspicuous, pick up noise from rubbing on clothing. Microphone is in the chest or the waist, but speech is directed at ear level. Bone conduction aids are used in mild to severe hearing loss. Its advantage is bypasses the middle ear, used if ear canal is unable to tolerate it or ear mold, or for unilateral hearing loss. Its disadvantage, receiver causes pressure on the scalp, which can be uncomfortable, does not correct sensory loss, being replaced by bone anchored. It's being replaced by bone anchored hearing aids. The cost of hearing aids and assistive listening device varies a lot. The assistive listening device being the cheapest is $100 and up. It's used for specific situations. As for the hearing aids, they range from digital, economy value to premium. It can come in 1 to 2, and as the price range increases, it has multiple programs and its facilities and features increase with the price. But unfortunately, the hearing aids and the assistive listening device are not covered by Medicare. Over-the-counter aids, they are recently approved by FDA for the sale in the US, solid direct-to-consumer. Quality varies from poor to good. Encourage consumers to have hearing tested before purchasing over-the-counter aids. Caring for the hearing aids can be by storing them, store the battery, the compartment door open, leaving the battery door even partially shut may drain the battery. Wipe dry with dry clothes daily. Consult manufacturer instruction prior to cleaning wax from sound outlets. The cochlear implant is an electronic device that bypasses the function of damaged or absent cochlear hair cells by providing electrical stimulation to cochlear nerve fibers. Implantation requires a pre-plant testing, post-plant testing, and general anesthesia. Cochlear implant procedure is covered by most Medicares, unlike the hearing aids. And insurance companies, although prior authorization is generally required. The outcome for adults of more than 65 years are comparable to those of younger adults with excellent audiological and quality of life measures. Overall, hearing loss occurs commonly among older adults and may lead to reduced quality of life, high medical care costs, and loss of independence. Primary care providers should routinely screen older adults for hearing loss. Treatment options are available for many types of hearing loss. So we have 3 cases to solve. I'll give you some time to answer the questions. So I'll start with the first case. A 72-year-old man has difficulty hearing, dating back about 5 years. He is accompanied by his daughter. Both are concerned about what is causing the hearing loss. The daughter says that he sets the TV volume exclusively loud, often does not understand full conversation, and has difficulty participating in conversations in noisy environments. The patient has no tinnitus, vertigo, otalgia, or discharge from the ears, and has had no ear infections or trauma. Which of the following is the most appropriate initial step in evaluating the patient's hearing loss? Everyone can participate in the chat box by leaving their answers. I see a lot of answers ranging between A and B's, but the answer to this one is C, because the initial step in evaluating a patient's hearing loss will be to perform the pneumatic otoscopy. In this case, the patient has presbycusis, but we should take it in a systemic approach and start by examining the external ear canal first. Okay, so let's move to the second case. 78-year-old woman has difficulty understanding conversations in noisy environment. She is referred for audiology evaluation. Audiometry results, mild hearing loss at low frequencies, sloping to profound loss at higher frequencies, hearing thresholds for air and bone conduction overlap, speech discrimination 83% in the right ear and 85% in the left ear. Which one of the following is the most likely cause of this patient hearing loss? Okay, I'll give you 20 seconds to answer this one. Okay, everyone. So I see a lot of C's. The right answer is C. This is a sensory neural hearing loss. The patient has presbycusis, and it's shown by mild hearing loss at lower frequency, which are sloping down to profound loss at higher frequency. Okay, we'll move on with the last case. A 63-year-old man comes to the office for follow-up related to an audiogram done 1 week ago. The audiogram indicates moderate mixed hearing loss. The ear-bone gap indicates a component of conductive hearing loss. The patient is interested in hearing amplification and requests a referral for hearing aids. Which of the following is the best next step? Okay, I'll have 20 seconds to answer this one. Okay, so I see a lot of B's, and the right answer is B. We have to refer the patient to otolaryngologist first, so he could be assessed for the hearing loss and to determine what type of hearing aids he might need. Okay, thank you, everyone. Is Dr. Huzaifa back?
Yes, I'm here. Hello, everyone. Sorry, I have a technical issue in my device. Thank you so much, Dr. Liena and Dr. Shahad, for this great, insightful and pleasure presentations. Thank you so very much. So, our next presentation will be a topic about types of research study, observational, cohort case study, and cross-sectional experimental. It will be presenting by Dr. Amin, but unfortunately, Dr. Amin is unable to attend today due to health issue. I hope him doing well. So instead of him, it will be presented by Dr. Liena and Dr. Shahad. Are you ready, Dr. Liena? Can you share your screen or I share it?
If you can share it from your side, it would be better.
Okay.
Okay, so Dr. Shahad, we'll start the presentation.
Thank you, Dr. Liena. The presentation is about understanding medical research study designs and the type of research. The purpose of this presentation is to explore types of medical research studies to aid clinical understanding and application. It helps in interpreting literature and making evidence-based decisions. Classification of medical research. It is classified to primary and secondary. The primary includes observational studies and experimental studies. The secondary research includes systemic reviews and meta-analysis. The primary versus secondary. The original data will be collected by you in the primary research. For example, surveys, focus groups, interviews, observations, and experiments. It can be either qualitative or quantitative studies. The key benefit is this is specific to your needs and you control the quality. Their disadvantages, it usually costs more and takes longer. In the secondary research, the data collected by someone else, for example, the act of looking for existing data is secondary research, and it can be either qualitative or quantitative. It is usually cheap and quick. Data can be too old and or not specific enough for your needs. The primary research study design. It can be experimental or observational. Experimental, like randomized controlled trials and non-randomized controlled trials. The observational studies include cohort studies, case control studies, cross-sectional studies, and ecological studies. Observational studies. The researcher observes without intervening. It is used when experimental manipulation is not ethical or feasible. Their types are cross-sectional, case control studies, cohort studies, which is prospective or retrospective studies, ecological studies, case report, and case series. The observation study. We will ask ourselves a question: does it have a conversion group or not? If it have a conversion group, then it will be a cohort study, case control study. If not, it will be cross-sectional studies or case report and case series studies. Case report versus case series. Case reports, which generally consist of 3 or fewer patients, are prepared to illustrate features in the practice of medicine and potentially create new research questions that may contribute to the acquisition of additional knowledge in the literature. When it comes to case series, involve multiple patients. They are a qualitative research method and include in-depth analysis or experiential inquiries of a person or a group in their real-world setting. The case report study have a key part of which is abstract introduction, the case presentation, which includes history, physical examination, diagnostic, treatments, and clinical course from the patient records. Then when it comes to discussion, it includes epidemiology, pathophysiology, clinical presentation, diagnosis, treatment, and prognosis. And lastly, conclusion and references. The cross-sectional studies is defined by data collected at a single point of time. For example, survey of hypertension prevalence in adults. When it comes to strengths, it is quick and cost-effective, but cannot establish causality. Here a graph for the cross-section study. There is cases, controls, and we will define the exposed patients at a single point of time and non-exposed patients. Case control studies. It is comparison between cases and controls, and the people will have condition or not. For example, study linking smoking to lung cancer. It is good for rare conditions, but have some limitations like recall bias and cannot establish incidence. This is a graph for case control study. We will define cases and controls, then define the exposure or the risk factor. cohort study. We will follow groups based on exposure over time. The data in the prospective cohort study, the data collected moving forward. The retrospective cohort study using existing records to follow backward. For example, the smoking and COPD development. Okay, we will define the exposure firstly, or the risk factor, and then the outcome. Here's a retrospective study from the records of the patients. Cohort prospective will follow the patients over time. Ecological studies. It is defined by examining the population level data. For example, country-wise control versus heart disease rates. Its strengths are generate hypotheses, but have some limitations. It is prone to ecological fallacy. Here's a graph. The study design that uses group level or aggregate level data, like the potential association between two variables, like average dietary fat intake and breast cancer rates. So I will leave the rest for my colleague, Dr. Liena.
Okay, moving to the second part, it's about the experimental study overview. Experimental study, the researcher intervenes to measure the effect. It's gold standard for testing treatments and determining the causality. We have different types of experimental studies: randomized controlled trials, non-randomized trials, field trials, and community trials. The randomized controlled trials, participants are randomly assigned to intervention and control. Example, a trial comparing new antihypertensive drugs to placebos. The advantages, it's minimized bias and it's considered a gold standard. Non-randomized trials, participants are allocated by method other than randomization. It has higher risk of bias than RCTs. The example is before and after hospital intervention study. We have also field trials, which are conducted outside clinical settings, such as it evaluate preventive strategies. Example, vaccination programs. We have also community trials in which entire communities receive intervention. Example, water fluoridation to reduce dental cavities. And the secondary type of research includes systemic review and meta-analysis. Systemic review is a structured summary of existing studies. It follows a defined methodology and protocol. It helps inform clinical guidelines. So the concept of systemic review is that multiple studies are taken and a systemic review process is done. Okay, meta-analysis, it's a statistical combination of results from multiple studies. It provides overall estimate of effect size, and it improves the power and generalizability. Okay, so we have several steps in meta-analysis and systemic review. The first being protocol development and registration, systemic research, screen for inclusion, PDF retrieval, metadata annotation, outcome data extraction, meta-analysis, and publication, finally. Okay, so the summary table of study types. The comparison on study types is based upon the study design, example, strengths, and limitation of a study. In order to choose a study design, we have several considerations to put in mind, such as the research questions, the ethical constraints, available resources, and desired level of evidence. In conclusion, study designs guide evidence strength. each type has a specific application, and research are essential and is essential for clinical research interpretation. Okay, thank you everyone.
Thank you all.
Thank you.
Great presentation. If there is any questions, please go ahead, Dr. Huzaifa.
Yeah, thank you, Dr. Liena and Dr. Shahat, for this great presentation. So, our next presenter, presenting topic will be presenting by Dr. Muayyad. He will present urine analysis presentation. Dr. Muayyad, do you hear me?
Hello, everyone. Yes, I'm hearing you.
Yeah. Can you share your screen or I can share it?
Yes, of course I can.
Okay, share it.
Okay, is it clear?
Not yet.
Okay, you can share it, Huzaifa.
Okay. Well, Dr. Muayyad, did you saw the screen?
Okay, yes, I see it clearly.
Yeah.
Yeah, my name is Dr. Muayyad. I'm going to present to you urine analysis. Okay, slide number 2. Dr. Huzaifa. Dr. Huzaifa, slide number 2, please. Next slide.
Hello, Dr. White, did you hear me? I have a technical issue in my other device. I can share it. Let me.
Okay.
Dr. White, can you try to share it because I have a technical issue.
Okay. Now do you see it?
Yeah, please.
Do you see my screen?
Yes, we can see it.
Okay.
It's clear.
Okay, Bismillah. Urine analysis, also called urine analysis or urinalysis, one of the oldest lab procedures in the practice of medicine. Also called as urine RNM, routine microscopy. It is an array of tests performed on urine and one of the most common tests. Why we use urine analysis? For general evaluation of health, diagnosis of disease or disorders of the kidneys or urinary tract, diagnosis of other systemic diseases that affect the kidney function, monitoring of patients with diabetes, a screening of drug abuse, such as sulfonamides or amino glycosides, or such as etc. In the past, urinalysis was used for monitoring the patients with diabetes, but now they use blood testing. It is better. Okay. Collection of urine specimens. Urine collection is very important thing. Improper collection may invalidate the results. Containers for collection of urine should be wide, mouthed, clean, and dry, and should be analyzed within 2 hours of collection, else require refrigeration. Okay. Types of urine sample. This table showing the urine samples and sampling and the purpose. Sample type, random specimen. For example, sampling, no specific time for it. Most commonly used, taken any time of the day. The purpose for routine screening, chemical, and FEME, which is full examination and microscopic examination. Morning sample, first urine in the morning. This is most concentrated, used for pregnancy test or microscopic test. Sorry? Clean catch midstream. Discard first few mil, then collect the rest. This is used for culture. 24 hours urine sampling. All the urine passed during the day and night, and next day first sample is collected also. Used for quantitative and qualitative analysis of substances. Also, we have postprandial, which is 2 hours after meal. It will determine glucose in diabetic monitoring. We have also suprapubic aspired. This is used with needle aspiration, and the purpose is for obtaining sterile urine. Urine analysis. What to look for? We look for the following measurements: microscopic or physical examination, chemical examination, microscopic examination of sediment, which is the cellular part of the urine, for urine culture. Okay. Physical examination of urine. We'll start by it. Examination of physical characteristics like volume, color, odor, pH, specific gravity, which is used with a refractometer or a reagent strip for measurement of a specific gravity. Let us start by volume. The normal volume of urine is between 1 to 2.5 liter per day. Oliguria, when the urine output is less than 400 ml per day, seen in dehydration, shock, acute glomerulonephritis, renal failure, etc. Polyuria, urine output more than 2.5 liters per day, seen increased water ingestion in diabetes mellitus and insipidus. Anuria, urine output less than 100 ml per day, seen in renal shutdown. Physical examination continued. We see color of urine. The normal color of urine, pale yellow in color due to pigments, urochrome, urobilin, uroerythrin. Cloudiness may be caused by excessive cellular material or protein, or crystallization or precipitation of non-pathological salts upon standing at room temperature or in a refrigerator. Color of urine depends on its constituents. The color. Abnormal colors, we have colorless, which is found in diabetic patients or patient taking diuretics. Deep yellow, concentrated urine, okay, or seen in excess bile pigments in jaundiced patients. This is a table showing colors of urine: blue, green, pink, orange, red, brown, black. Blue green seen in methylene blue, which is taken for bowel integrity. We see blue green urine in Pseudomonas infection, in taking riboflavin also. The pink, orange, or red in hemoglobin, myoglobin, phenolphthalein, porphyrin, and rifampicin. Red, brown, black, hemoglobin, myoglobin, red blood cells, homogentic acid, L-DOPA, melanin, methyl DOPA. Odor of urine, normal, it is aromatic due to volatile fatty acids. On long study, the urine become ammonical due to ammonia decomposition, which is decomposition of urea forming ammonia, which gives a strong ammonia smell. Okay, it may be also foul smelling, offensive pus, indicate offensive pus or inflammation. Sweet odor in diabetes, fruity odor in ketonuria, maple syrup like in maple syrup urine disease, rancid in tyrosinemia, rotten egg odor is seen in kidney stones, for example. The pH of urine reflects the kidney's ability to maintain normal hydrogen ion concentration in plasma and extracellular fluid. Normal urine pH ranges between 4.5 to 8. This is in general. And if it is between 6 to 6.5, it may be slightly acidic. Testing methods. We use litmus paper, pH paper, or dipstick. Acidic urine have a lot of causes. It may be ketosis in diabetes, starvation, fever. Okay, systemic acidosis may be also a cause of acidic urine. UTI, which is caused by E. coli. Acidification therapy, any therapy make urine acidic. We come to a physical examination. Also, we have a specific gravity, which is a measurement of urine density, which reflects the ability of kidney to concentrate or dilute the urine relative to plasma from which it is filtered, measured by urinometer, refractometer, dipsticks. We have normal range of specific gravity, which is between 1.001 to 1.040. This is a table showing specific gravity corresponding to osmolality of urine. It is relatively proportional, directly proportional to each other. Increased specific gravity causes low water intake, for example, diabetes mellitus, albuminuria, presence of albumin in urine, acute nephritis. Decreased specific gravity causes absence of ADH, antidiuretic hormone, which is in diabetes insipidus. Renal tubular damage also can cause decreased specific gravity. We have fixed specific gravity, which is called isotenuria, a specific gravity of 1.010, okay, indicating the kidneys cannot concentrate or dilute urine, for example, in chronic kidney disease. We have also in microscopic examination of urine some steps: centrifugation, slide preparation, and then microscopic observation. In the centrifugation, a well-mixed urine sample, 10 to 15 ml, for example, is centrifuged in a test tube at a low speed of 2000 to 3000 RPM revolution per minute for 5 to 10 minutes. This concentrates the sediment, which is a cellular matter at the bottom of the tube. Then the next step is the slide preparation. A drop of the sediment is transferred onto a glass slide. A thin glass over a slip is placed over the sample. Then step number 3, microscopic or observation. The prepared slide is examined under a microscope for analysis. A variety of normal and abnormal cellular elements may be seen in urine sediment, such as red blood cells, white blood cells, mucus, various epithelial cells, various crystals, bacteria, and casts. Hematuria is defined as presence of abnormal numbers of RBCs, red blood cells, in urine due to causes such as glomerular damage, tumors eroding the urinary tract, kidney trauma, urinary tract stones, acute tubular necrosis, upper or lower urinary tract infections, nephrotoxins. Okay, WBCs, which is the white blood cells, in high numbers indicate inflammation or infection along the urinary tract. This is a microscopic examination of urine under a microscope. We see RBCs in urine appear as a refractile disc, and WBCs here appear like this. We have also in the examination the casts. Urinary casts are cylindrical aggregations of particles that form in the distal nephron, then dislodge and pass into urine. In urine analysis, they indicate kidney disease if you see it in urine. They form via precipitation of something called TAM Horsfall mucoprotein, which is secreted by renal tubular cells in the collecting ducts and distal convoluted tubules. These are the types of casts: hyaline casts, and this is granular cast, RBC cast in urine, and WBC cast in urine. This is also about the crystals, normal crystals, uric acid, calcium oxalate, and so forth. The chemical analysis of urine, also important thing, is undertaken to evaluate the levels of the following components, which are protein, glucose, ketones or cold blood, bilirubin, urobilinogen, and bile salts. The presence of normal and abnormal chemical elements in urine is detected using dry reagent strips called dipsticks. When the test strip is dipped into urine, the reagent on the strip are activated, initiating a chemical reaction. This chemical reaction produces a specific color change on the strip. After a predetermined amount of time has elapsed, the resulting color is compared to the reference color chart provided with the dipstick to interpret the results. This is the urine dipstick method, and this is the reference color. Proteins in urine. Detection methods used. We can use heat coagulation or dipstick method. Sources: plasma protein and TAM Horsfall glycoprotein. Normal excretion level should be healthy individuals excrete less than 150 milligram per day of total protein and less than 30 milligram per day of albumin. This is the chemical analysis of urine evaluation for proteinuria. Proteinuria in urine dipstick, if it's quantified by 24-hour urinary secretion of protein and albumin or forest morning spot albumin to creatinine ratio, if you have 3 to 300 milligram per day, it is microalbuminuria. You should consider early diabetes or essential hypertension, early stages of glomerulonephritis, especially with RBC cast. If you have 300 to 3,500 milligram per day RBCs or RBC cast on urinalysis, in addition to disorders listed under microalbuminuria, consider myeloma, associated kidney disease, such as intermittent proteinuria, postural proteinuria, congestive heart failure, fever, exercise. If it is more than 3,500, it is nephrotic range. nephrotic syndrome, diabetes, amyloidosis, minimal change disease, and membranous glomerulopathy. Thank you so much. Do you have any questions?
Thank you so much, Dr. White, for this informative presentation. So
Thank you.
our last presentation, I will present professionalism in healthcare, and professionalism maintaining ethical standard and demonstrating empathy and compassion adhering to hospital policy and procedure. So I will share the slide. Okay. Did you saw the slide?
Yes.
Hello?
Yes.
Okay. So the presentation is about professionalism in healthcare. So in this presentation, we will talk about what is the professionalism and how can we implement this in the curriculum, and also how can we teach it and how can we assess it. So first, what does professionalism mean to you? Take a few minutes and write down your side definition of description. Okay, we can skip this. So what is a professionalism? It is not easy to define a profession, but it's like to have all or some of the following characteristics. First of all, it is a vocation or calling that implies service to other, or it has a distant knowledge based with which is keep up to date, or to determine its own standard and set its own examination, or is it a special relation with those who has a service like patient, student, etc. It has a particular ethical principle. Though professionalism is a term which embodies numerous quality of the physician as a public service. It has been described by the American Board of the Internal Medicine as constituting those attitude and behavior that serve to maintain other interests above physician self-interest. The project of professionalism by American Board of Internal Medicine 2001 develop the physician character and identify 6 key elements of the professionalism. There is a 6 characters characterized for the professionalism. First of all was giving the priority to the patient interest. The second was
by being answering
answering to a patient society. Number 3 was effort to perform beyond ordinary expectation. Number 4,
Dr. Liena, did you show the slide?
Okay, I'll share it. Just a second.
Can you share? Can you share the presentation?
Yes, just a second.
Yes.
Is it
So,
clear?
yes, it's clear. As we said, the professionalism consists about six components. One of them are altruism, and we talk about the accountability, and then the excellence. It consists effort to perform beyond the ordinary expectation and commitment to lifelong learning. And number four was a duty. It is like a free acceptable of commitment to service, like undergoing to inconvention to achieve a high standard of patient care. And number five was honor and integrity. This by being fair and truthful, straightforward, and keeping to one work. Number six was respect for others. We respect for patients and families, colleagues, and other healthcare professionals and students and trainee. These are four components of the professionalism X. The concept of professionalism include the following value as we saw: honesty, trust, service, commitment, communication, accountability, and lifelong learning. So again, we defining the professionalism and what specific behavior are unprofessional in the classroom and the clinical setting. So example of unprofessional behavior in classroom setting or student or trainee in hospital, in clinical, in classroom setting or student, like unprofessional behavior like arriving for class late and or leaving early. Number two, being unprepared for group sessions and not completing assigning tasks. Also, disrupting the class session and familiar feeling to attend a scheduled class session and cheating on exam. This example for professionalism behavior. Also, using of mobile phone during class, chatting during class, focusing on the test, visit learning, projecting content in advance, tolerance of the opinion of other, all this unprofessional behavior. In classroom setting, our faculty, like in research, plagiarism, in judgment, attitude, or favorism, and coming late to the meeting or to the lecture, slobbing hat out and style abusive behavior, or using mobile phone during classroom or presentation. In unprofessional behavior in clinical setting, uh, example like tracing inappropriately in the hospital. Number two, avoiding work and responsibility. Number three, and exhibited little empathy for patients, and also demonstrate lack of sensitivity to patient culture backgrounds, and not protecting patient confidentiality. This all of them was unprofessional behavior in sitting hospital. Uh, Also in clinical setting, faculty showing on favorism, failing to attend or scheduled session, using inappropriate language or behavior, and also asking learning to perform personal tasks, for example, picking up laundry. Common example in hospital or clinical skill, marketing for a new drug or conflict between the government with this private uh, commitment. Private hospital visit governmental hospital. So sign and symptom, the work of project professionalism by the American Board of Internal Medicine describe unprofessional behavior in terms of seven broad categories of sign and symptom. First of all, abuse of power. Abuse while interacting with patient and colleague, like bias and sexual harassment and breach of the confidentiality. Number two, arrogance, like offensive display of the superiority and self-importance. Number three, greed, when money became the driving force. Number four, misrepresentations, like lying, which is consistently failing to tell the truth, and fraud, which is consists mispresentation of material fact with the intent to mislead. And number five, impairment, any disability that may be preventing the physician from discharging his or her duty. Number five, lack of consistency, failing to fulfill responsibility. Number seven, conflict in interest, like self-promotion, adversing, or unethical collaboration within the industry. Acceptance of the gift from patient and misuse of service, overcharging, unappropriated treatment, or prolonging contact with patients. This all was an professional sign on symptom. How professionalism can be implemented? Professionalism can be implemented if we don't do our task of the curriculum design by performing of the task or approach to task. If any defect of this, it will be it lead to unprofessional behavior. So this was the level of approach of the task until reach professionalism. For example, in the right here as knowledge, patient management, patient investigation, clinical setting, clinical skill, practical procedure, health promotion, and disease. These all, if any mistake in one of them, it will be unprofessional. In the left side, decision making and skill and clinical reasoning and judgment. Also basic social and clinical sense, and personal development and lifelong learning, and also role of the doctor with the health service community. All of them, if any mistake on one of them, it will lead in unprofessional behavior or sign of unprofessionalism. Next. So let's talk about the role of the doctor within the health service and in personal development. In health service, doctor role is in understanding of the healthcare system. It should be the understanding the health system. Also, understanding of clinical responsibility, appreciation of doctor as a researcher, appreciation of a doctor as a mentor or teacher, appreciation of doctor as manager include quality control and teamwork. In personal development, professionalism, example in lifelong learning, self-awareness, self-confidence, self-regulation, like self-care, self-control, personal time management, and also in motivation by achieving drive, commitment, or initiative. Also in career choice. This all was a role as a personal or doctor in professionalism. How professionalism can be taught. Next. Professionalism in the curriculum. There is a strong support for professionalism to be considered in the curriculum. A learning outcome, a skill set, a competence. Many of medical schools have their integrated curriculum containing about professionalism within their curriculum and added course on the professionalism in the first 2 years or have to introduce behavior into the clinical clerkship. In all medical schools in the world, it is mandatory to teach professionalism to medical students. Curriculum content relating to professionalism. The key attribute of professionalism: professional, ethical, decision-making, moral, reasoning, humanized, multilateralism, empathy, value, storytelling, care for the vulnerable, tourist attitude and communication, confidentiality of patient data, contact with the patient, emotional intelligence, and mental health and self-assessment by using the reflecting practice. Those should be integrated into the component course of the curriculum rather than tough as stand-alone course. How can we teach professionals? By rolling modeling, bedside teaching, simulating patient, and small group discussion. This is the image of that. Yeah, follow me. How can professionalism be assessed? Okay. We assess the professionalism according to something called Miller triangle. First of all, by assessment and computer-based or written from down to up. From the down of triangle by noise, know how and show how and thus how. First of all, you will assess the professional about the professionalism by the assessment, computer-based or written. After that, the assessment will reflect on his portfolio. Okay, that's the similar triangle shows that. Next, using suitable assessment tool by multiple choice question and faculty evaluations and clinical vignette and standardized patients is also for the assessment. Also, assessing by the rating scale and having been used to assessing the professionalism in variety of the setting, like for example, using rate scale in the self-assessment, direct observation by faculty, and OSCE station per assessment, and the 36-degree assessment. All these above rating scale have demonstrated validity and feasibility for the assessment of the professionalism. Also, reliability, and however, in many of these examples is not yet available, but this can be used. How can we assess professionalism? As we said, by evaluation, per evaluation, patient survey, staff evaluation, professionalism, portfolio, this for self-evaluation, and 36-degree evaluation, 600 evaluation. So, take a home message from you, from me, and you. Professionalism should be a part of the formal curriculum, and professionalism must be tough and assessed, and also must be relevant to the society it serves. This word from Kant says that there is a tendency to underphases the personal character because they are harder to measure, and to overphases the more easy measure Index of Academic Achievement. This counts is a American writer said that in 2022. Next. Thank you very much for the listening, all audience. There is any question or comment, this our end of the of the meeting. If any comment.
Thank
So
you, Huzaifa.
if
Dr. Huzaifa, you did a
so
great presentation.
if no we have reached the end of our meeting, and I would like to hand over the floor to Dr. Nadir for this closing, of course. Thank you so much, everyone. Dr. Nadir.
Thank you so much, Dr. Huzaifa. This is also a great presentation, and it's one of the important topics. So in your future, you're gonna encounter this in different environment or settings where you go in residency or at work in other places. So it's an important one. Any questions? Thank you once again to all presenters. Next topic will be the updates. Any project updates, new ideas?
Sorry, Dr. Nari, you are muted.
Thank you. So any updates? I'm going to share with you this idea. Maybe some of you might be interested. So in the past, we developed 5 mobile applications. One of them is the dental group. They did that and published it in Apple Store. It's called Dental Care Reminder. And I'm going to share with you the screen here. So the dental group created this app, and they were successful in publishing it at Apple Store. So the idea is to see if we can improve or we can work on getting this published in other platform or stores like Google Play Store. So this is basically the basic idea of the app. It has different icons here. You can see it has alarm where the user can add the timer or timing of the day when they want to do the cleaning, for example, or brushing or any activity. And there are some videos to show some of these activities and instructions and so on, and some information or advices for the users. So this can be in Arabic or in English. So alarm video, articles, tips, and maybe advices. So it's very simple program in itself, but it may be useful. So for some reason, I don't see it in the app store. If you click on it, it's just gonna go to this web. And if you go to the app store itself, it's not listed. But there are different other, when you search about it, it's not listed, but there are different other apps that we can look at, and we can get some features if we want to improve the app, for example. So Dr. Wala Farah, are you still with us here? Yeah. So perhaps Dr. Wala is a dentist in our group, and maybe she can, and her other dental fellows, they can work on improving that. So for example, this one created an app for kids, and it's kind of has music, so they can get the timing when they brush for how long, 2 minutes or so. And then it can also educate them about dental caries and so on. There are other apps that are in Arabic or other languages. So what I think we can do is we can work on improving this, and maybe we can add features. We can create a similar one and add it to the Google Play Store. So I added it as a new project in the project list. If you go to the app, you click here, projects, and it's project number 106, and you can add yourself to the team. So you don't have to have any idea about programming. You just want to be able to share your time and your effort. So the team leader will find out what the ideas from the group and what the features they can do and how they can build the app, first of all, to the Google Play Store. And if they want to add new languages, let's say we have many Spanish speakers here, or Indian or Pakistani, they want to work on developing similar app or the same app but with different language. So we can add this. So these are just simple ideas that we can work on. The other thing that the team can work on is the spread the word about the app and testing the app. So to develop the app, it's a process, but one of the steps to do it is to create the app and test it and make sure there is no bugs or problems before you submit it to the App Store. Or when you submit it and publish it in the App Store, you ask also users to test it and try to see if there are other questions or anything that can be improved from the user aspect, or if anything that can be fixed or enhanced. So these are things that the team can work on. You don't have to be a dentist, you don't have to be a programmer or have ideas about the mobile development app. We have some of the fellows who already went through the process and they know how to develop the app in Google Play Store app, so they can help. One of them is Dr. Amal Al-Amin and also Dr. Nafisa and other in their group. So the process itself can be done, but if you are interested, you can work on developing a team, and then you can have a team leader for that project and see what the task and how we can achieve that. And this can be to all fellows. And again, the idea is to help your patients, your families, your friends, your communities. And when you have an interview, you can talk about this, and it will be an innovation in your CV. You will be unique compared to other applicants in any field, like the dental group or the medical group. If you are applying for residency, if they ask you, you will be a unique applicant to that program. So I hope this is useful for you guys. And if you have questions, let me know. Any questions? Any new ideas or okay? Dr. Ryan Hamza, please go ahead.
Assalamu alaikum, everyone. Hello,
Alaikum.
Dr. Nader.
Hello.
I am Ryan, one of the new fellows in group 2, Walnut, and I
Yeah.
have a new idea on systematic review. But I would like to ask how can I take approval for the project. I tried to write the protocol of the review, but I'm completely new to this type of study design, and I'm looking for supervision mainly. And
Sure. So what first of all, welcome to the program, and welcome all new fellows. And what you need to do is, I think we will send you a link to the WhatsApp group. We have a big group where you have seniors and new fellows. You can ask for guidance as far as what if you have a specific question, they can answer some of the fellows who did some of the systematic review. So if you have the idea, please send me an email about the topic, and we can discuss what you can do and how you can go about that. My suggestion is to see if there are fellows who are interested in your idea, and then create a team. Hopefully we will have 10 or less fellows, and the reason is if you are submitting to a conference, for example, as a poster, they will have, some of the conferences have limited author numbers. Some of them might be 10 or less. So we don't want some of your team members working hard and then their names are not listed as authors. So this is why the limitation. But you can create the team, and then when you have the idea and the steps to create the project and accomplish it, what we call the task, you can divide the task to the group. So in your team, group 1, for example, 2 fellows can work on writing or reviewing literature about what if it's already done, your idea, or what background, what's the significant, and so on. And then maybe another 2 fellows can work on getting a literature review using certain databases and certain keywords and so on. So you will have some task, and some of the fellows in your team can do that instead of you doing all the work. It's going to be faster, and it's going to be teamwork, and you can be the leader for that project. And the reward for all of you will be great if it's accepted, or you can change that into a manuscript where you can submit it to a journal, for example, to be an article. So these are the things that I suggest, and you can ask some of the seniors in the WhatsApp group. But welcome, and great to hear from you.
Thank you, Dr. Nader. Okay, I will send you the protocol for your approval, and if you have any feedback,
Will do.
inshallah.
Inshallah. Jazakallah khair. Thank you. Anybody else? So Dr. Huzaifa added the link, and if you are new, you have the WhatsApp link for the big group, you can join the group. So, and another update, I just had a call from one of the fellows in this program, Dr. Myra. She is in Florida, and she just called me, and she was accepted to psych residency program. So congratulations to her. She will join us next week, and she will give us her tips and advice, and share her experience. She spent about 2 years in this program, and successfully she matched to a program in Florida. So congratulations. So any questions from the new fellows in this meeting today? So if there is no questions, I'd like to thank you, Dr. Huzaifa, and your team, all the presenters from today. Thank you so much for great presentations. And I'd like to thank all the fellows who joined today, and those who will watch the recording in the future. Thank you all, and I wish you all the best. If you have questions, please reach out, and I'll be happy to help. You can email, you can call, or text me. And have a wonderful day, or have a wonderful night wherever you are. Assalamu alaikum. Thank you once again. Bye-bye.
Thank you, Dr. Nader.
Thank you very much.
Dr.
Thank you.
Nader.
Thank you.
Thank you, Dr. Nader.
Thank you.
Thank you, Dr. Nader.
Thank you so much.
Thank you, Dr. Nader.
Thank you, Dr. Liena. Thanks.
Thank you, Dr. Nader.
Anytime. Thank you.